Welcome to the 3030 Health Podcast. The following discussion is for education and entertainment. It is not intended to diagnose or treat disease. Please do not apply any of this information without first discussing it with your doctor. Here is your host, Dr. Ruiz.
Hello everyone, super excited about my show today. My guest today is Dr. Paul Anderson. Dr. Anderson is a recognized authority in the field of integrative cancer research and the treatment of chronic diseases, genomic conditions, and autoimmune and infectious disorders. As a naturopath, Dr. Anderson began his career as a family practitioner in Canby and Salem, Oregon. For many years, he has trained students and clinicians at a number of naturopathic medical schools and other higher education institutions, with a specialization in intravenous therapy formulation and infusion techniques, as well as clinical approaches to complicated illness. This is a super exciting episode. I hope you enjoyed the show. Hello everyone, super excited to have Dr. Paul Anderson, the dude of naturopathic medicine, on my show today. Dr. Anderson, how are you?
I'm wonderful. How are you?
Doing great. Just super excited to have you. You might not know me, but I know you really well. Throughout my naturopathic medical school, we've used your videos and your tutelage to get us through boards and to get us through different scenarios in our education. So super thankful for all your work, for your expertise in all things naturopathic medicine. And in true 3030 Health podcast fashion, I want to ask you, Dr. Anderson, what is your hero story? How did you end up as a naturopath?
Well, that goes back a ways. It's a lot like I think a lot of other people's. I suppose the short version is that before I went back to school and did naturopathic medicine, I was actually working in the medical field in the end of laboratory medicine, and I actually own my own lab. And so when that was all going on, my children were little. Actually, just the first two were born. And we kind of had that same problem a lot of parents have where the kids get sick and then they go and get antibiotics and they get sick again. And, you kind of in this revolving door with illness. And, to cut through a lot that went on, I was just very, very impressed with this doctor who'd been around a long, long time. And he really helped the kids. And then I started to see him, and he really helped me. One day I was in his office with one of the kids, and I could do this. This seems like an interesting career. And really, it all kind of started that way. It was watching it work, and then deciding that maybe I wanted to do that as well. So it's been a long time, but that's what started it.
And I think you're known within the naturopathic medical realm because of your innovative approaches to different disease processes. And you're always at the cutting edge of emerging things. And you treat, I've heard you talk about biofilms, and now they're all the rage. And you've been talking about biofilms for a very, very long time. So it's always, very interesting to me how do you keep yourself at the forefront of things? How do you research things, or how do you get a wind of the trends before they even happen?
I think about that sometimes. I think that one of the things that, this is just my assessment of why that all happens, but I think one of the things I've noticed is I've always had a very busy practice, so I've always seen a lot of patients. And one of the things that I think because of my curiosity, one of the things that happens is you draw people who have unusual problems. And when you get enough people like that together, and you are running into treatment, failures or treatment that goes slow or something like that, I think it makes the curious person a lot more curious. And so you start looking for, well, what can we do better? What can we do differently? And so that sort of moved forward now that I'm a clinic director and I have other doctors working with me who do, a lot of patient care, and I manage from the top down. It's just an extension of that, where now we get more and more complicated patients, and we you can't stop looking for answers because no doctor knows everything. And certainly a lot of these things that we see as emerging or, cutting edge or whatever, they're out there. It's just nobody's, to any large degree worked with it long enough to kind of figure out what the next step is. So I guess that's, if I have a gift, it's the gift of curiosity, and it causes me that sort of thing.
Yeah, you did a couple of a series of interviews with Dr. Michael Ruscio, good friend of mine, consider him one of my mentors. And, I've been digging into the biofilm stuff. I totally learned so much in that, in those two interviews about all of the things that you're doing. That if any one of my listeners is interested in chronic infections, do yourself a favor and go listen to that interview. And one of the things that I started doing that I hadn't done before was using biofilm disruptors before doing a stool analysis.
Yeah.
And that really has changed the results that I'm getting on my patients. Can you talk a little bit about biofilms and what are biofilms? Why do we get chronic sinus infections, or why do kids end up getting chronic ear infections that get treated with antibiotics and maybe it goes away and then it comes back? How come we as a healthcare system haven't discovered how to properly treat an infection and do it once and then get it completely resolved?
Yeah, I think it's a really good example of, I think, a couple of very important things. One of them is, and I'll talk about biofilms kind of technically in a second, but I think what I've seen, because I've been around patient care for over 40 years now, so I've been doing this a while, but people are generally sicker than they were 10 years ago, and they're way sicker than they were 20 years ago. And I think that more than these resistance factors becoming more entrenched or better or something like that, I think we as hosts are becoming more of a target for resistance factors such as biofilms, et cetera. And I think that there's a number of reasons why we're getting to be better targets. It's things that, sort of wear us down, things that, we don't see or maybe we don't perceive, such as getting stronger and all these other things that, we just don't, it's sort of like we're getting weaker by a degree at a time. So we don't notice it. But I think, what I've seen is 10, 20 ago, most infections were not this hard to get rid of and all this stuff. So one of the things that led to me looking back into biofilms as a resistance factor, which is really what they are, was this phenomenon of the patient seeming to be in this revolving door of, they do something to kill infection, it comes back, or you get a child with a PAN syndrome and they get the right treatment, but it just boomerangs back around. They're back to the same problems, and you get these people, Lyme-like illness or Lyme disease, and they've been treated for 3 years, and nothing's dead. Obviously, there has to be something behind that. So the journey, and it's not just biofilms, but biofilms are a really interesting phenomenon. They're natural. They occur in all aquatic life. They're a way for microbes to protect animals. They're in any moist area. So think of your digestive tract, your teeth is where we first found them in humans, even the blood vessels, etc. But really what they are is there's certain bacteria that like to start the biofilm construction. And then the thing that we've learned in the last decade is that in that constructed biofilm, there is the ability for that then to take in other things that don't make biofilm, so we don't even think that they're there. Things like viruses and certain protozoas and all manner of other other bugs. And so what you wind up with is, while there are totally normal biofilms, everyone has non-pathogenic biofilms. They're just part of, it's like having normal flora. But there's a spectrum of pathogenic ones that go from kind of what I call the weaker ones that are easier to break down to the heavier ones that are harder to break down. And I think what we see in the research kind of backs this up. In people who've had big insults like chronic infections or chronic illness that they just their vitality is run down, they build bigger and better and badder biofilms. And so the biofilm is a way for these organisms to they can share DNA, they can do all kinds of interesting things. And something that a biofilm researcher told me as I was kind of on this quest was the other thing that, doctors have a hard time wrapping their head around is now they're not really fighting with one bug like we're used to. You're fighting with a community. And the community might be made up of different types of organisms. Like I said, you could have virus and protozoa and bacteria and all kinds of stuff. And now they're mingling, sharing, they become a whole other thing for your immune system to deal with. So a biofilm, while totally natural, is something that the wrong bugs can use to kind of get a leg up and then hide from your immune system. And like you said, this concept, and again, 10 years ago, nobody was really thinking about this, but this concept of doing some biofilm disruption and then doing a stool test, as opposed to just doing stool tests, that made a lot of sense to me because I started seeing all these people with normal stool testing, but all sorts of gut symptoms. And it made no sense, at all. And so we started doing what you mentioned. We do some biofilm disruption, then you see more in more quantity and more variety of bugs coming up on the tests. And so it's sort of proof of concept that they are hiding, and you have to go after them. So I think that's been it's been a real revelation because it explained why so many people were not getting better, even with despite the very best treatment that we could do. And I think it's one of many things.
The way I explain it to my patients is that, for example, you have a chronic sinus infection. You take, your Z-Pak, or you take something that is not really meant for that cavity, and then you kill some bacteria. The bacteria go into oh shit mode. They start making biofilms to hide. So you do get better for a couple of days. And then when the bacteria starts reproducing, they have a really fast reproductive cycle. Now they're inviting other pathogens to get shielded. And that's how you end up with like these chronic infections that are very, very persistent. And had we, started with maybe a little bit of a biofilm disruptor, maybe a low dose antibiotic in a rinse form through a neti pot, and maybe some sort of probiotic. I know there's pretty cool chewable probiotics that actually make it to the sinus cavity and take residence in that area. Maybe you don't need to do multiple rounds of antibiotics. Maybe you do one treatment and that's it. But because we don't start there, we have to resort to the bigger guns and the bigger guns. And eventually bacteria are going to be resistant to things like Beck spray and all of these different compounded antibiotics that we have.
Oh, sure. Yeah. And I think, as you describe that process there, what you tell your patients, if you think about it, it makes complete sense that if the clinicians leave the idea of biofilms out of their calculus for figuring out what to do and what's gone wrong, then you do what you've always done. You hit it with the antimicrobial substance or whatever, and if that's not hitting the right target, or it's not not big enough to hit the right target, you're just going to make everything stronger. And I think that's what we've been doing for 30 or 40 years probably, which is part of the other reason that the biofilms I think are so good.
Or in vogue,
Yeah,
but then we think of biofilms and it's easy to imagine a biofilm, in your sinus cavity. But you made a really strong argument about biofilms in the gut, and maybe what we were misdiagnosing as candidiasis, maybe what we were actually treating with herbs and with N-acetylcysteine and all of these cool compounds was actually biofilm.
Yeah, I think so, and I think that certainly the respiratory system it was the place right after the oral cavity where we accepted that there were biofilms, which is the respiratory system. So certainly the respiratory system is well known to have biofilms at this point. But what I have seen as I've done, clinical work with biofilm disruptors is when you have them in the digestive tract, the immune response is, it's 10 to 100 times greater than an immune response from your, respiratory system, which is pretty remarkable. And I think the reason is that the GI tract has normal biofilms, but then you get the wrong microbes, and they just accentuate it. And I think that's why, like you say, you've got people, and that, that used to be an extremely common, I mean, it still is, extremely common thing is a person that has candida, they get it treated, and it's right back. Why does it come back? Well, it comes back because it never actually left. Of SIBO and all kinds of other enteric phenomenon. You get those people with parasites that, they get treated with drugs and natural stuff, and the parasite's still there. There's got to be a reason it can live through all that. And I think biofilms are a huge part of that.
It's super interesting. Sometimes you treat someone with a biofilm disruptor, and they will get worse before they get better. Why does this happen?
Yeah, that's a phenomenon. That's another one that it's funny. I have a conference in a week or about a week and a half, and I'm putting together a clinical manual for it. And I just finished the biofilm section, so it's fresh in my mind. And I think this is something that doctors have a hard time with, which is they have a patient who has been statically ill for a long time. They disrupt the biofilms, and all of a sudden the immune system just doesn't even know what's going on. So it's sort of like, the bugs have been there, but it hasn't bothered them. Then the immune system goes after the bugs to its best ability, and it creates this inflammatory response and all this stuff. And suddenly the patient goes from one day everything's fine, and then the next day they're just in this inflamed, immune flare. And they don't understand why. The doctor often doesn't. Well, the reason is it's like you have, this giant ball of fire that's been covered up, and suddenly you took the lid off. That's really what going through a biofilm does. Now, for patients, of course, be careful with languaging that, because what you don't want to do is say, well, you just got to tough it out. It's going to be bad. There's ways to deal with the immune system and the inflammatory system so it's not so bad. But they do need to know it's going to, you're opening Pandora's box to a degree. If biofilms are a problem and you go with a strong biofilm breaking substance, they're going to have an immune response, and you need to be ready for that. And it's predictable, what's going to happen. That's good clinical medicine. Doctors don't always think of. They don't think it can be that bad until they see it.
Yeah, and it can be pretty scary too.
Yeah, especially you get somebody with PANS or pandas, they have neurological symptoms. They get very bad.
Yeah, they come in because maybe they're constipated, or they come in because maybe they're bloated. And then you go, oh, I have it, let's do some interface, or let's do, some like hardcore, EDTA or something like that. And then all of a sudden now they have a fever, and they have neurological symptoms. And I was like, dude, I would rather just had the bloating. Now I feel like I have the flu times 10.
Yeah, that's exactly correct. And to a degree, that's how it's part of the problem, because there's no other reason they would have that reaction from a biofilm breaking substance unless there's biofilms there. So in a sense, I got to the point where I'd always warn people ahead of time, look, this is what we're going to do, but there's this possibility you have these, kind of stealthy infectious things, and we need to be ready for that just in case it happens.
People might not know that whenever you take something like echinacea, it actually increases your levels of IL-8. IL-8 is what makes you feel kind of crummy. It gives you a fever. But that's how your body is going to endogenously attack the virus, because nothing is better at killing viruses or bacteria. No natural supplement, no antibiotic, no pharmaceutical is going to be as effective and thorough as your immune system. So this acutely elevated IL-8 is actually going to cure you faster. But what other things can we do with like cool IV therapies or supplementations in order to modulate that response and actually get you out of that crappy situation faster?
Yeah, I think that there's at least two or three parts to modulation, and I think that's really important because this is the other side of the clinical question. When somebody really flares up, you can go to the other end of the spectrum and supplements and their other cytokines, and it'll shut the reaction off. But then the problem is that your body's not naturally responding to the problem. If you don't do anything, you get an over response. And so what we do, and the way that we think about it is, if the person can handle the reaction and it's just they're okay and they can go do whatever and kind of get over it, it's not a big deal. But some people, the reaction is just really wild, like crazy. So what we tend to do with people like that is a couple of things that are the goal is modulate the immune and the cytokine and the chemokine reaction, but don't shut it off. So make it livable without shutting off the natural infectious immune response. And so there's a number of things that we do. So like basic things that we'll do with people, one of which is very helpful can be oral boswellia and curcumin. They're a really good combination where they're not suppressive, but they're very leveling to these chemokines. The use of intravenous glutathione is really useful at these times when glutathiones are big water-soluble antioxidant along with vitamin C, and it doesn't function, but it can help kind of quell the side effects of the reaction. There's a number of other things that we'll do. Occasionally we'll do something that might even make the reaction a little stronger, but then resolve quicker. So something like a lower moderate dose vitamin C IV with some added zinc, you'll kick up your IL-1 and your IL-8, so you get a little more fever and stuff, but it'll be over faster. So if we got somebody with a good vitality, we'll often do stuff like that. And there's a lot of other strategies too, but the bottom line is we want to allow the reaction, but we want to make the patient comfortable without shutting the reaction off. And that's a little bit of a tightrope walk, but it can be done.
And it's super interesting because we can apply these concepts to a bunch of things. For example, what happens when your immune system is overreactive? You might have a chronic infection that you're not resolving, or you might have some food allergies, or you might have some endocrine disruptors or heavy metal toxicity. So you have an overactive immune system. So we can go the pharmaceutical route and give you something that is going to be completely immune suppressive. The biologicals, which I'm super excited about your A&P track on biologics. But then that predisposes you to other things, such as cancer.
Exactly, yeah.
And I know that you are an expert in that subject. You just released a book on cancer. What are some take-homes from your book to whet my listeners' appetite into going and digging this book out?
Yeah, so and that's an excellent point about the biologic medications. A lot of them are associated with higher levels of certain cancers because while they're shutting off one problem, they're letting the immune system down in another area, so that then if cancer is developing, the immune system can't see it. And we talk about this a lot in the book. So the book's called Outside the Box Cancer Therapies, and it's published by Hay House, and it's Dr. Mark Stengler and myself wrote it together. And we wrote the book in a unique way. We knew it would be unique, but we didn't realize how unique till we got it done. And the reason that it's unique is we wrote it at the level that any patient or family member or caregiver, loved one, anybody can understand what we wrote about. We didn't write it like a textbook. But what we did like a textbook is we referenced it like a textbook. So there's almost 1,100 references, so over 1,000 references. And we did that, so it's referenced just like any textbook, but we did that because many patients will go to their doctor and they'll say, hey, I'd like to do mushroom extract with my cancer. Doctor, well, I don't think there's any research on that. And this way they can say, well, at least take a look at these citations in the book, because there's a lot of research on it. Or we want to use some other thing. For instance, we have a section on IV therapy. We have a section on therapies we don't find in the U.S. but are in other countries, and why is that? We have a section on both primary prevention, so don't get cancer, and then secondary, which is don't let cancer come back. So we kind of go into all of the most common areas people with cancer deal with. And so in outside the box cancer therapies, you've got a patient-friendly writing, a patient-friendly style, but they have the references if they're curious, or if their doctor's curious, they can kind of step back and say, oh, well, there is some research on that. I didn't know that. So Mark, Dr. Stengler and I were in medical school at the same time a long time ago, and we had kind of lost track of each other. I mean, he was in Southern California, I was in the Northwest or in Arizona, depending, and we met at a conference I was teaching at about cancer, and we had dinner, and we decided that between the two of us, we had these kind of meandering paths into the world of cancer. And so we were able to take these two completely kind of different ends of the spectrum paths and come up with a lot of really great information that, so for example, a lot of the oral therapies, he had, tons of research on, and he did a lot with that, a lot of the IV and the other therapies, I had tons of research. So it was really a good melding. And we've had a lot of really great feedback from patients. I get, messages or whatever from people who have cancer and said they really are, enjoying the book and it's helping them. So it's been really gratifying to see that.
Well, let's take it out and do a bird's eye view, So what are some things that we can start doing today to prevent cancer? Because that's probably going to be the best way to treat cancer, just to never get it. And what are some things that are kind of obvious to everyone, and they're not going to be new, but, you would think that they have the biggest return on investment?
I think you're exactly correct that, the least expensive way to treat cancer is to prevent it, not get it. And because, there's differences of studies on percentages and all that, but, somewhere between 40 and 50%, or maybe a little bit more, of cancers are preventable, according to the research. So you got to think about, okay, what is it? So number one, what is it that creates cancer? And then what is it that I can do to get at not creating cancer? And so one of the things we have a whole chapter in the book on this, but I'll just shorten it up to say that there's three kind of points of view about where cancer comes from. And they're all correct. They're just different. They're sort of looking at it from different angles. And so we have kind of the predominant theory of the last 50 years, which is the somatic mutation, or the genomic theory. And there's certainly some genomically caused cancers, but they're certainly not all that way. And what we see is that you get two people, one, they have the same genes, one gets cancer, the other one doesn't. So why did the one with the same genes not get cancer? Well, obviously there's other factors, epigenetic factors, et cetera. So there's genetics, that's a viable option. There's the metabolism idea, which is that cancer metabolism and healthy cell metabolism are different. And so, if we get too much inflammation and too many of these cytokines you were talking about going the wrong direction, metabolism goes off, and then the cancer is permitted. It's allowed to grow. And then the third is not really even a theory; it's a well-known fact, and it's called the cancer stem cells. And the stem cell idea, which is an outgrowth of a very old idea that they were talking about stem cells, they didn't realize they were 100 years ago, because we didn't know about stem cells. And nowadays we just call them cancer stem cells. Well, they are important in that even if you have cancer, you don't have cancer. The cancer stem cells are really what drive the resistance and the reemergence of cancer. So we all have cancer cells that develop every day. Our immune system takes care of them; they go away. The cancer stem cells, if we are not swimming in a direction to keep them calm, they will start to send out daughters that will develop cancer. All three of these ideas meet. Now, then you have to say, well, what can I do to keep all of them as happy as possible? So you can't change your genetics, but you can keep your epigenetics calm. And it turns out that keeping your epigenetics calm and healthy will also feed into good metabolism, and it will feed into the cancer stem cells being quiet, that's all we can ask, is keep the cancer stem cells quiet. What I've come to over time, and this is something I'm going to share at Southwest College next week when I'm down there, is in looking back at all the cancer therapies I've done and people I've worked with, and who got better, who didn't, who prevented, who didn't. There's three foundational pieces, and what I've really come to is if these three foundational pieces are taken care of, then the prevention takes care of itself. And then if you need cancer therapy, it'll work better. And so the three big foundational blocks, and here's what I tell patients, if you don't have these three foundational blocks that you're working on, we can do good therapies or good prevention, and it will fall through a bad foundation. And so it's really important that the foundation, and the reason patients sometimes don't like this advice is the foundation is in their control. It's not in the natural.
Yeah, well, yeah, you cannot pay for the foundation. You have to, it has to be self-motivated.
Yeah. The foundation is about you and your behavior, not the doctors, and that's hard on us humans, So, but the first block is a big one, and it's how you feed your body, obviously, and this goes to a number of things. But it's easy to remember food. So the first thing I like to point out is that we live in a very, very toxic environment, and food is one of the quickest ways for toxins to get into our body. So the first thing we should do is not be adding toxins in any more amount than we have to our food. And so that means clean sources of food. And of course, there's no place in the world, there's no food that's totally clean, but we can do better or worse, with how less toxic we make things. So cleanliness, very important. The next thing is the quantity and the type of foods that we're going to eat. And so that goes to a couple of things. One is quantity has to do with any nutrient category that we overfeed our body can become fuel for cancer, and cancer stem cells can be fueled by it. That especially goes for sugars and carbohydrates, but it also goes for protein. The reason for that is that we need certain amounts of these things, but when we have extra, either we get chemistry that goes bad and creates a pro-cancer environment, or we break down, and let's say we get too much protein all the time. We'll have extra protein that breaks into amino acids that have no purpose because we're maybe not using our body enough, or we're just eating too much, and then that will create a pro-cancer environment, et cetera. And then the final part about eating, which I was really excited that some human research, there's a lot of animal and other research on this, but some human research came out before we got the book published, so we got to get it, and that is timing of eating. And so if in the one big, human study site, breast cancer survivors, they divide them into two groups. They didn't even care what they ate, which imagine if they cared what they ate, but they didn't care what they ate. They just divided them into eat what you want, when you want, no restrictions. Other group was eat what you want, but you have 13 hours a day, so after dinner, but before breakfast, where you're not eating, you drink water, but basically you're fasting for 13 hours. The fasting group had a third, and there's tons of other research that shows simply by time restricting your eating, and we're not talking about starving, it's like you still eat every day, but by time restricting your eating, you reset your body chemistry, these cytokines and chemokines and your insulin response, all that stuff. It resets, and when you do that, it takes the inflammatory action in the background down a lot. And what that does is it sort of unplugs the pro-cancer chemistry. So as a prevention strategy, these big points about eating, so cleanliness, what and quantity you eat, and then the timing you eat, huge preventive things. The middle one, the middle block, there's 3 blocks. Middle block is muscle. And the more muscle mass you have, the better your skeletal muscle is, the less cancer you have. The more fat mass you have, the more cancer you have. And also, if you already have cancer, more muscle mass equals longer life. More fat mass equals shorter life. And it goes back to muscle activity and muscle mass drive good metabolism. Fat mass drives bad metabolism. And, to the degree, if you're in prevention, you don't want to get cancer, you just got to keep your core muscles, legs and the core postural muscles, the whole center of your body, keep them working, keep them active, keep your fat mass down, and keep your muscle mass up. Super preventative. But also, let's say you have cancer, it works, and the more muscle mass versus fat mass, the longer you live. It's very clear in the research. And that's because the fat cells create inflammatory chemistry. Muscle cells create a very prevention chemistry. So we got what we eat, how we use our body. Third thing, the brain. And again, this is in our ballpark. Now we can get help with all these things, but these are, what I eat is my responsibility. Whether I work out or not or move, that's my responsibility. And how I think is my responsibility. The thing about the thinking part is, this is also borne out in the research that if you, this is the same with any chronic illness, but cancer, same thing. If you feel that they feel that, cancer is being done to you, and you have nothing you can do about it, you are less likely to live very long. Also, if as we all know, when people have nobody wants a cancer diagnosis. So when we get a bad diagnosis, what do? We go through the stages of grief, basically. So you have, denial and then anger and bargaining and acceptance, all those stages. That's fine. You do that. What I have seen repeatedly is if they get stuck somewhere, denial, anger, whatever, those people don't live long either. And it's because they're either angry and their energy is not being focused in a concrete direction, or they're in denial, so they have no energy, or they're some other intermediate place. And so I think that it's really important that we honor the fact that a cancer diagnosis is horrible, nobody wants it, but what you do with it in your brain, and there's a lot of good people to help with this, a lot of good counselors and things, but what you do with it in your brain makes a huge difference. So if you're looking, whether it's any end of the spectrum, if it's total prevention, you've never had cancer, what you eat, how you eat, when you eat, how clean, move your body, what you do with your fat and muscle mass, and then how you think about things, those are your big prevention strategies. Everything else then is easier when you got those in place.
That's so interesting because, the way I'm thinking about it is about resources versus infrastructure. And it seems that at least in the food aspect of things, and even in the muscle aspect of things, you just want to have enough resources to feed your infrastructure. If you have more resources coming in, i.e. calories or food, what ends up happening is that all the pathways that feed, all this muscle building and kind of get saturated, and then your body doesn't know what to do with the excess resources. So you start making bad cells, and that's how you start feeding cancer.
Yeah, no, it's totally true.
Now, once you have cancer, if someone has cancer, what are some steps? How can, let's say they went to the primary physician and they said, oh, sorry, you have breast cancer. What would be like your ideal patient, or how can we talk to our friends about what steps to take? Because I am in a bind a lot of times because I am a naturopath. But we do have to respect, our allopaths because they do have some answers. They don't have all the answers, but we don't have all the answers either. How do you best navigate that very touchy subject of how should you actually do a truly integrative approach to cancer?
Yeah, and I think that's the most important practical question that we all, whether we're a patient or a doctor or a family member, we have to deal with. The first thing is it comes down to has to be in agreement with whatever. Okay. So, because we get this a lot, now you've probably seen it, where a family member really wants the patient to do a particular therapy, but the patient actually is not into it. And if it's sort of, we go back to that thing about the brain and where your brain is. You can't make somebody do anything. Whether it's a traditional oncology approach or a naturopathic or whatever. So the first thing is, are you okay with this? Is this something you want to explore? Next thing is, and this was a real fun thing, we got to write about in the book, was we really focus on every patient situation is unique. And so you can have two people with breast cancer and two completely different interventions or recommendations that you give, because you may have different level of vitality, you might have different stages of breast cancer, you might have different reactions to treatment. All of that has to be calculated in. So, for example, we give an example in the book. We say, if you have a cancer that has a standard, oncology treatment success rate of 90%, you should do that standard treatment. If it's got a 90% success rate, please do it. The thing that doesn't rule out is there's like 90% of the case that the integrative or naturopathic doctor can take care of. The standard therapy takes care of that 10%, but it's important 10%. On the other hand, if you have a cancer or you stage 4, it's widely disseminated disease, and you have no chance or 5% chance, the standard treatment's going to cure you, then you have a whole different set of calculus to go through, different rules. And so the first thing is having somebody who's informed and wise enough to take you through that part. Then it's a matter of saying there's really no, right or wrong here. So if I got a patient, they got a 90% success rate with their chemo and radiation or whatever they're doing, we're going to do that, but we're going to support them through it so that they come out the other end as healthy as possible, and then we're going to work on prevention. If I got somebody, with pancreatic cancer and they got a 3% chance of survival with standard treatment, their oncologist often will say, you shouldn't even do what I'm offering you because it's so bad. Like, the stats are so bad. Well, that person, we're gonna really kick up the intensity of their treatment, and we're gonna really get aggressive with standard of care things, because standard of care isn't going to do anything. So it's really about being rational, but also meeting the person where they are, letting them know what the reality and the stats are, and then saying, regardless of whether the standard of care is great or not great for you, we do all these other things that keep you alive, that help you with the standard treatment, that, if the standard treatment doesn't do anything, we got stuff to do for your immune system to work with the cancer. So a lot of it's just about being reasonable and rational. And I think, that's something that, 20 years ago was really hard to come by, because most people in integrative and naturopathic oncology was a fairly new world. And we weren't well enough informed to say, oh, X cancer, we're going to go this way, and Y cancer or Z cancer, we're going to go these other two ways, because cancer is not one thing. So anyway, that's a long way to say meet the person where they are, and then there's a lot of really logical, scientifically based ways to say you need a lot of standard of care type therapy, or there's no reason for you to have any of it, and here's what we can do, and here's what we do anyway.
Dr. Paul Midman, I was having a conversation about this integrative approach to care, He said that while he was going through school, people would laugh if you said, "Oh, naturopathy is prime for integrative care." This is, 20 plus years ago. And now oncology is at the forefront. That's where we shine. It's at the forefront for integrative care. No one has any answers. We don't have a sure way of doing it. But in this collaborative system, we can really make a lot of progress, especially when it comes to quality of life. So how things have changed.
Oh yeah, yeah, totally, totally. And I think, and I've seen the same thing Dr. Mittman has, because we've been through the same, I guess, time period. It's not that long ago where most people would say, you're a tiny, kind of marginal fringe healthcare group, and we don't really even think there's any benefit to what you do. And I think that if there was no benefit, it's not so much what other providers say, but if there was no benefit, there would be no patients who would come to us, and we have plenty of patients who we can help. And I think that it's an important evolution. And the other side of the coin is we still have the same conversations all the time around, is what you do valid? And, this patient has cancer. I don't want you to be involved and all this stuff. But it's way different than it was 20 years ago. It's moving in a better direction. And I think we just have to we keep getting better. We educate ourselves. We build bridges with the other doctors, and we move into a place where, the other doctors trust us, the patients trust us. We can really help people.
So let's we're about an hour long, and this is such an amazing conversation, but we've been kind of on the sad notes. What what are some exciting things within cancer and oncology that are exciting for Dr. Paul Anderson? Give me some brightness to my day.
Yeah, it's always hard to talk about cancer, because it's not it's not the most fun topic. Here's something that I would say, and I'll just kind of boil it down to a couple of things. One of them is, if I was a cancer patient and I had the choice of seeing someone like myself now or seeing someone like myself 20 years ago, I would take now. Not just because we're 20 years older or we whatever, but the state of the art, the state of the science, the state of integration is light years ahead of where it was. And I know, back 20 years ago, I knew most of the people in North America who were doing integrative and naturopathic oncology, and I know what we were doing, and I know what we do now, and I know what we know now, and I know how fast things are evolving and changing. So there's not a better time for somebody to use an integrative and a naturopathic approach when they have cancer. And the other thing is that translates to better outcomes, but also better quality of life, better everything really. So what excites me is that we have gained so much in these last decades, and what you gain is not sort of, just a little stair step. It's sort of like once you get through 20 stair steps, now every new step forward is another 10 stair steps. It's, the curve just goes up. And that's because you build on all this past knowledge and experience. And I'm very positive about and very excited about what we know now and where we can go with it. And and I see in our clinic and in my colleagues' clinics, we're helping people in ways we never could have before, which I think is really, really incredible.
Now, I'm always up for a good conspiracy theory. Why do you think that there are some cutting edge cancer treatments that are available outside of the United States and not here?
Well, and I don't think it's probably even a conspiracy. We, know this, but the listeners may not. I am called to sometimes testify for a lot of integrative and alternative therapies with government agencies. In fact, I'll be doing that Friday morning at 8 a.m. With
Well, thank
respect
you
to
for that.
cancer. Yeah, it's great. But here's the thing: let's say there's no bad intent or conspiracy or whatever, but it's just why does this happen? Because I have a hospital, for example, that I consult for that's in Mexico, and we do all kinds of things there that are the same as what we do in Europe and other parts of the world, and they're for cancer and they work, and it's totally not a problem. But here I can't do most of those things. Why is that? Well, let's say there's not a conspiracy or whatever. There's a paradigm problem. We have a medical system in North America that evolved out of really a financially driven model, and the financially driven model drives the research. And if you ask any researcher in the world, but especially if they're doing it in North America, if you don't do your research and get it approved in America, you can have all the German or Japanese research you want. Americans won't believe it's real. And so there's this bias, there's an inherent bias. Then there's the fact that the financially driven medical system drives who gets paid for research. What drives the financial, system? It's the fact that we're a pharmaceutical treatment-based medical system, and we got a few other, financial bases. So those are the things that drive who gets paid for research. It's not about what's best to research. So then everyone looks and says, well, we don't have American research on these things, so we're not going to do them. Or no one's going to make any money on this, so we're not going to do it. And so that's really what happens. And I was testifying at a federal government agency that deals with medications, and we were talking about something that is very inexpensive, that is used in cancer therapy around the world. We did it in our research and all this stuff, and if you use it correctly, it's very safe, very effective in combination with other stuff. And they said, well, you don't have the right kind of research to prove that this is safe, so we're going to deny access to it. And literally 6 months later, 2 different drug companies were licensed to have this same molecule as part of a chemotherapy regimen, and they're going to be able to sell it for any amount of money that they want, but now it's licensed to these people. So there's a lot of it that's, because people will say, well, if it was that good, why wouldn't the government approve it or whatever? Well, it's just, there's this big shell game that goes on with who's got the money and, all that stuff. So I think that's why. You look at something as simple as hyperthermia, which is used everywhere else in the world for infections and cancer and all sorts of stuff. Here, it's still experimental.
You can go to Canada and get hyperthermia treatments.
Yeah, I mean, either Canada or Mexico. You can go across either border and you get hyperthermia. So yeah, it's just and that's just one of many, many things.
I'd like to talk, just one more question, without naming names. How do you feel about compounding pharmacies putting their products through FDA approval? And now, we have to go through them in order to get them. Now, I understand that, it's for the safety of the population. And now we're going through one provider. So now they've created a monopoly. Thankfully, they didn't jack up the prices of this particular product. But do you think this is going to trend that a lot of people are going to make a lot of money on, or should we be thankful that these companies are doing that?
That's a very insightful question. Here's the thing that I've seen over time is as the government oversight increases on an industry like compounding pharmacy, they have to pay more money to stay in compliance, et cetera, and that creates a higher margin for them, a lower margin actually, a higher cost structure, and so that gets passed on to you and me as the doctor. And so it's not like, the thing is, nobody's really making any more money. It's just more expensive for the patient. because we have to meet all of this criteria, et cetera. And it's a two-edged sword. So there's the safety thing and all of that, very, very reasonable to have safety, et cetera. But what happens is, and if you've been around a while, you've seen this, when they impose more and more restrictions, only the pharmacies that have a lot of money can live through that, can stay in business. And so there are many, many, many compounding pharmacies that I used to work with that were just fine. They're no longer in existence because they just can't afford to stay in business. So then it's supply and demand. That means then that the product falls to fewer hands. And now what you have is there's some IV products, for example, that only one pharmacy makes because no one else wants to invest the money in making it.
And it's a very commonly used IV product.
Yeah, I mean, there's actually a number of it. Like for our clinic where we do a lot of stuff, we literally have to have relationships with about 10 compounding pharmacies just to get everything we need, because the pharmacy will tell me, look, you're the only person that buys this one thing. I'm not going to make 25 vials of it and throw away 20 of them, because they have to make a certain amount and have them tested and all this stuff. And so, yeah, it's created this. It's not really competition on the pharmacy level. It's, if I'm a pharmacy, do I want to invest the money in making this thing? And some of it's easy to make, and everyone makes it. Some of it's harder to make, and only 2 people make it or 1 people make it. So it's really a mess, and it's the oversight that's driven it. Of course, we need, we want sterile compounding to be good, and we don't want anyone hurt by it, certainly. But the regulatory changes in the last 3 or 4 years have driven a lot of places out of business, and it only affects the patient, and it only affects the patient negatively. And as a matter of fact, this other government thing I'm involved with Friday morning is all about that, and it's about a government agency restricting access to healthcare, and they feel they're completely within their rights, and we disagree. So yeah, it's a real. I mean, it's never been like this ever. I mean, I've been around for a long time. I was around in the 90s when they took B-complex off the market for 6 months, and it came back. That was the worst thing that ever happened to us back then. Now it's insane, and so it's a problem. And if you do want to indulge in conspiracy things, all of the products that I have been lecturing about since we did the research that was actually funded by the government about cancer, every single product I've ever talked about cancer pretty much has come under attack from the government about access, and it's always cloaked in, oh well, it's not safe, or it's not this, or it's not that. But I could give them many examples of other things that are much less safe that are used every day in medicine. So I think it's interesting times we live in. We're kind of in a culture war is what we're really in, and the real problem is, and what really gets me is it's the patient who suffers. It's our sick patients that don't get what they need, and that's a shame.
And not to say that IV therapies are 100% benign and super safe. People do get injured, but that's why we have licensing bodies, and that's why we go to school, and that's why we go to seminars, and that's why we train, and that's why we now have to have a hood in our office. So we are trying to help people, and when it comes to IV therapies, I've seen some amazing things with glutathione and with vitamin C and with B12 and using hydrocobalamin instead of methylcobalamin, and the intricacies of things are so amazing, and you can do some like life-changing and medicine from the future now, because we can be so specific with our therapies, and that's why I love IV therapies. But unfortunately, the more in this aspect, the regulation is misguided. Yeah, I think that there should be regulation. It shouldn't be the wild, wild west. I don't trust myself to mix my own B complex at the office. But having a pretty good compounding pharmacy that adheres to the rules, and they send them to me, and then I use sterile technique to put together a bag for my patient. Doesn't matter if it's 3 ingredients or 12 ingredients. I went to school for a pretty good amount of time. I think I can handle that.
Yeah, I'm pretty sure you can.
Dr. Anderson, thank you for all you do. What are your next appearances? Where can people find you? How can people get a hold of you?
Yeah, so the book is Outside the Box Cancer Therapies. This from Hay House. You can get it on Amazon or Barnes and Noble. That's one good way. The other, our clinic, if you're looking for that, you can find us at Advanced Medical Therapies online or on Facebook, Advanced Medical Therapies in Seattle. And then for people looking for the medical education side of my world, it's consultdranderson.com. So just consultdranderson.com. And there's all kinds of stuff on there. And there's a interactive calendar, shows where I'm going. I'm going to be, as we were talking about, I'm going to be down in Scottsdale in about 10 days. I'm putting on a brain recovery conference. And so that's what I'm doing with every moment until then.
Awesome. Thank you so much for being here. Thank you for all you do. Thank you for your NPLEX preparation videos. They really saved my ass. And we'll be at A&P. I'll be doing a presentation on quinolones and herbs, and you're gonna have a whole track dedicated to the biological drugs. So that's gonna be super exciting.
Yes. Yeah, that'll be good, and that's coming up too. So I got a busy summer.
Yeah. Well, thank you so much, Dr. Anderson. Let's see if we can circle around in 6 months and maybe open it up for questions to my listeners and have another fun show, because it's really insightful and always great to pick your brain.
Let's do it. Thank you so much for having me on.
I'll talk to you soon.